Hello, my name is Edward Smit and I'm a professor of pulmonary medicine at the Netherlands Cancer Institute, also called Antonie van Leeuwenhoek Hospital in Amsterdam, the Netherlands. It's my pleasure to welcome you to this discussion of HER2 dysregulation and novel HER2 targeted treatments in non-small cell lung cancer. And I'm fortunate to be joined here with my colleagues, Dr. Yarushka Naidu, who is a consultant medical oncologist at Beaumont Hospital in Dublin, Ireland, and Dr. Caterina Politi, who is an associate professor of pathology, Yale School of Medicine, Connecticut, the USA. Here's the agenda for today's discussion. We will cover three topics. The first one is to address the question how HER2 is dysregulated in non-small cell lung cancer and what is its clinical relevance in patients with advanced non-small cell lung cancer. Second is what are the current challenges in treating patients with HER2 mutant non-small cell lung cancer. And last, we will discuss the latest data on HER2 targeted therapies for patients with HER2 mutant non-small cell lung cancer. So I will now kick off with the first question. How is HER2 dysregulated and what is its clinical relevance in patients with non-small cell lung cancer? There are actually many ways HER2 can be dysregulated in non-small cell lung cancer. A small proportion of the patients their tumors harbor a HER2 mutation, which appears in approximately 2 to 4%, but I think 2 is actually the better figure here. And the majority of these mutations occur in exon 20. Most commonly, these mutations are observed in females, Asians, never smokers, and patients with adenocarcinoma, almost exclusively, I would say. Next, you have HER2 amplification, so the whole gene is amplificated. Some of the patients who have HER2 mutations also have HER2 amplifications. But the number of patients that have actual HER2 amplifications is higher than patients who have a mutation. These amplifications are found in patients who have oncogene drivers such as EGFR or ALK, and are particularly found in patients that have been shown to be resistant to EGFR tyrosine kinase inhibitors and which may have HER2 amplification as a resistance mechanism. In some of these non-small cell lung cancers, we actually do not know the exact proportion of patients that harbor HER2 overexpression, somewhere between 2 and 38%. In these patients, a high expression is found in 2 to 6% of patients with non-small cell lung cancer. I think it's important to stress, and I think we can ask Katie later on in the discussion, that this is quite different from HER2 amplified breast cancer, and I would like to have her opinion on that later on. Is there a connection between HER2 dysregulation and clinical outcome? Well, yes, it seems there is. Although the prognostic impact of the most common HER2 mutation, exon 20 mutation, is unknown. But insertion mutations are definitely resistant to most HER2 targeting tyrosine kinase inhibitors. Overexpression, in terms of overexpression detected by immunohistochemistry, is an indicator of poor prognosis and is a possible association with intrinsic chemoresistance, as was found in several early studies. The prognostic value of HER2 amplification in non-small cell lung cancer is not clear and is based on anecdotal reports. And I think large series about the prognostic or even predictive value of HER2 amplification in non-small cell lung cancer is by and large unknown. So now I would like to introduce my two colleagues, where we have a discussion around this topic. First, I would like to ask Katie, how does HER2 dysregulation in non-small cell lung cancer compare with other solid tumors?
Yes, thank you very much for that question, Egbert. So HER2 alterations are found with variable frequencies in several different solid tumor types, most notably in breast cancer and gastric cancer, in addition to lung cancer. And HER2 alterations are also found, though, in other cancers, in uterine cancer, bladder cancer, colorectal cancer, amongst others. And what we know about HER2 alterations in non-small cell lung cancer is that we have mutations, amplification, as Egbert was just telling you about. But we know that the HER2 mutations are mostly represented by HER2 exon 20 insertion mutations. Instead, we know that, for example, extracellular domain mutations are more frequently observed in bladder cancer, and other kinase domain mutations, missense mutations in breast and colon cancer. So mutations in HER2 can happen across the gene encoding the receptor, and they're just slightly different frequencies of these different mutations in different cancer types. In terms of amplification, for example, we know that in breast cancer, HER2 amplification is an oncogenic driver there, and is also frequently associated with overexpression. So that kind of matches. HER2 amplification and overexpression often match in breast cancer. And in lung cancer, we do see HER2 amplification. It's not as closely linked, I think, to overexpression, at least from studies that have been done, and happens perhaps a little bit less frequently than we see in breast cancer.
Just about the immunohistochemistry, is that identical when you have overexpression in lung? Is it identical to breast, or is this completely different?
In terms of overexpression, well, I think even the sort of the link, at least, between amplification and overexpression isn't as tight as it is in breast cancer, in lung cancer. There isn't necessarily that close correlation between the two. I should note, one thing to keep in mind is also that HER2 amplification in lung cancer has also been observed as a mechanism of resistance to tyrosine kinase inhibitor in EGFR mutant lung cancer. And that was first described about 10 years ago. And in those initial studies, it was found to not co-occur with some of the classic on-target EGFR resistance mutations like the T790M mutation. And it's also been described in more recent studies of resistance to osimertinib in about 2 to 5% of cases examined, in the first and second line setting of use of osimertinib in EGFR mutant lung cancer. So there is a small subset of cases where that seems to be a resistance mechanism to EGFR TKIs in EGFR mutant lung cancer.
Okay. But I think the clinical relevance of those two groups of HER2 amplifications is quite different. Would you agree?
Yes, definitely. And I think, we'll probably get to that further in the discussion, that the mutations are really the oncogenic drivers in non-small cell lung cancer, as far as we can tell so far.
So, Jaruska, how often do you encounter patients with HER2 dysregulation or HER2 dysregulation, sorry?
Yeah, so I think this is a great question of clinical relevance to oncologists who treat thoracic malignancies, now that we recognize HER2 is a bona fide oncogenic driver in lung cancer. So we are testing for HER2 alterations since we have an open clinical trial in our institution. And I would agree with you that the incidence probably errs more towards the 2% rather than the 4%. In a practical sense, I think I probably see a patient with a HER2 alteration maybe once a month to once every 2 months. So this does appear to be quite rare, but still a subset of patients for which we have emerging agents, and I think we should be testing for.
Okay, so that 1 or 2 a month, is that any dysregulation or is that mutation?
Yeah, so right now I think the majority that I have seen has been mutation, since that is what we are testing for using NGS platforms. So
do you think a HER2 mutation has predictive value or has prognostic value? And how is that in your experience? Do these patients do worse? Do they have specific clinical characteristics?
Yeah, so I think we do appreciate that, like some of the other oncogenic driver mutations, such as EGFR and ALK, HER2 alterations appear to have a little bit more heterogeneity, as Katie mentioned, but certainly the HER2 mutations appear to follow that line, enriched in female patients, non-smokers, and patients with adenocarcinoma histology. I do think that HER2 mutations are a bona fide oncogenic driver. I've participated in a number of trials of different targeted therapies, such as positionib and pyrotinib in the subset, and I've definitely seen responses in these patients. So I do think that they are a therapeutically targetable subset. In terms of their prognosis, I think, again, there is heterogeneity here, but there does appear to be a subset of patients that may benefit from these agents and therefore have a slightly improved prognosis.
Does it have clinical consequences in terms of what you should not do? For instance, do you think, I have a strong feeling in this subject, immunotherapy, does this have a role in treating patients with HER2 mutations?
Yeah, so I think that's a really important question. We do understand that patients with EGFR mutations or ALK alterations may not benefit from immunotherapy. I think the data in these rarer subsets of patients is not as robust. And we have seen some publications where there are isolated incidents of patients who may still benefit and others who don't. So my understanding is we have more to learn in that space.
Okay. Okay, thank you, Jeroska, very much for these answers, and also you, Katie. And with that, I would like to close this discussion. So next we want to discuss the current challenges in treating patients with HER2 mutated non-small cell lung cancer. Current guidelines recommendations advocate testing in a number of genetic alterations. And you can see here a list of genomic alterations which according to ESMO and NCCN guidelines should be tested. And you may well appreciate that HER2 mutation is no in ESMO guidelines and no in NCCN guidelines. Nevertheless, both these guidelines recommend broad genetic profiling prior to initiation of therapy for advanced non-small cell lung cancer. HER2 testing is not currently recommended due to limited data, but recruitment into clinical trials is encouraged as we need novel treatments for these patients. I think the rate of mutation testing around the world is quite different, and it differs from a 45% in the United States, for instance, to 85% in my country for most common mutations, and we could have some discussion later on around that. Nevertheless, I think it should be stressed, and that will come back in the discussion as well, that patients should be treated for the most common genetic oncogenic drivers. Current treatment guidelines around HER2 dysregulations do not really advocate testing, but I think it's important, especially when you have NGS-based panels, that you should test for this mutation. So you could refer patients to clinical trials investigating HER2 targeting agent. If negative for actionable drivers, of course, patients should be allocated to treatment with platinum doublet chemotherapy, plus or minus immunotherapy, be it pembrolizumab or some other PD-1, PD-L1 targeting agent. So there's currently no standard of care for patients with non-small cell lung cancer and HER2 dysregulation. However, guidelines encourage recruitment into clinical trials with HER2 targeting agents. I'd like to open the discussion, Katie. Should we be testing, and how should that be done?
Yes, absolutely. Given the evidence, really, that HER2 mutations in non-small cell lung cancer are oncogenic drivers, and these emerging data on approaches to treat this subset of tumors, it really is important to test for HER2 mutations. And I think in general, in non-small cell lung cancer, given that we know that there are a series of oncogenic drivers, just as you just showed, and alterations, and that several of these are actionable or potentially actionable and have investigational agents also in clinical trials, really understanding whether the mutation is present in the tumor, whether there is a HER2 mutation or any of these other oncogenic drivers, is really, really important. So I think that we should be testing for HER2 mutations.
So Yarushka, at what stage should we do that? When they qualify for HER2 targeted treatment, or would you do that at any time, even up front?
I think that's a great question. So I think there are differences in terms of the practicality of when we would change our management based on the results of mutation testing and when may be prudent to do the test. So I think practically speaking now, we get lung cancer mutation panel testing upfront to look for oncogenic drivers like EGFR, ALK, ROS1, and others for which there are approved targeted therapies. In the case of HER2, where we don't necessarily have an approved targeted therapy yet, but we do have or potentially have clinical trials in the second line setting, I think there is some discussion as to when or how this testing should be done. I would agree that testing upfront would be optimal in order to know what alterations we have so that we can plan our treatment journey for a patient. However, having some of these results upfront, such as HER2, may not necessarily change our first-line treatment option.
Okay, so you would say do it upfront so you can plan for the second or third line treatment, because this mutation will not go away in the tumor.
Exactly. And also for the purposes of, for example, if we're doing NGS testing, we know that this is done through parallel sequencing where we can get a number of results at the same time. Whereas doing individual hotspot testing wastes our tissue, which is a particular problem in lung cancer. So going and doing the test after first line will likely exhaust the tissue and may result in not getting a result at all.
Okay, so talking about exhausting tissue, Katie, how about ctDNA? Will that be the future for HER2 mutation testing, or it doesn't matter on what biosource you test it?
Well, I think that the testing the tissue itself and performing the mutational testing on the tissue is an ideal approach to evaluate mutations and amplification, if that is something of HER2 or other genes, if one wants to evaluate that. Circulating tumor DNA approaches can be used to identify mutations as well. So that is another approach. If one is looking for amplification, that can be a little bit more challenging with circulating tumor DNA analyses.
Would you say the latter is experimental, or would you rely on it?
I think it's been used more and more for the identification of mutations in terms of the circulating. Yeah. If you're looking at mutations in circulating tumor DNA, so I think there's a broader experience now for the detection of individual mutations that are present, and for the identification of the mutations. So people are using it more.
But how about amplification detection, especially because there is, like you mentioned in the first discussion, in the setting of EGFR resistance, there is probably a reason to look for amplifications, both of HER2 and MET. Could that be done on circulating tumor DNA, or would you prefer tissue biopsy there?
I think there are reasons to look at tissue biopsies, especially in terms of analyses of data regarding amplification. It can reliably be assessed there. One could also use FISH analysis, for example, on tissue to evaluate amplifications. And I think just in general, if one is looking at resistance mechanisms, if we're talking in the context of resistance to therapy, one can also assess histological changes in the tumors. So that's where evaluating the tissue is especially helpful.
Okay. Thank you very much. I think we covered all the questions that we have around testing for HER2 mutations in non-small cell lung cancer. So we now would like to review the latest data on HER2 targeted therapies for patients with HER2 mutant non-small cell lung cancer. There are two classes of drugs that are evaluated against HER2 mutated non-small cell lung cancer. These are the so-called ADCs, or antibody drug conjugates, and the tyrosine kinase inhibitors. So there are currently two ADCs directed against HER2. One is called TDM1, well known from breast cancer treatment, and the other one is called trastuzumab deruxtecan. It's sort of the latest kid on the block. You can see here some of the study results. TDM1 was associated with an objective response rate of 44% in a small group of patients and had a median progression-free survival of 5 months. We did not see the overall survival results yet. And AEs included things you might expect, like low-grade infusion reactions, thrombocytopenia, and liver function disturbances. Trastuzumab deruxtecan is a novel molecule consisting of trastuzumab with a topoisomerase I poison attached to it, which was recently evaluated against 91 patients with metastatic HER2 mutated non-small cell lung cancer, eliciting an objective response rate of 54.9%, with a median progression-free survival of 8.2 months. And I think the most exciting part of this second and third line cohort of patients was a median overall survival of 17.8 months. And this was obtained at the cost of some toxicities. And I think the most relevant toxicity, and we'll come back to that in the discussion, was drug-related ILD that occurred in roughly a quarter of the patient and was also associated with a couple of toxic deaths. A couple of tyrosine kinase inhibitors have been designed to be especially effective against HER2 mutations, including poziotinib. My colleague Robin Cornelissen from the Netherlands presented at the latest ESMO meeting a phase 2 or a cohort of a large phase 2 study, including 48 untreated patients with HER2 mutations, where poziotinib was administered at a dose of 16 milligrams for an objective response rate of 44% and a progression-free survival of 5.6 months, which is somewhat at the higher end of what we have seen today of poziotinib, and a median duration of response of 5.4 months. I think what's important for this drug is it's associated with skin toxicity, grade 3 or more, and that led to a alternate dosing schedule that is now being investigated. Pyrotinib is another drug that has phase 2 data of 60 patients that were pre-treated with chemotherapy and had an objective response rate of 30%, a median progression-free survival of 6.9 months, and a median overall survival of 14.4 months, so in the same ballpark as T-DXd, I would say. Diarrhea was a problem with this drug, occurring in 20% of patients, grade 3 or more. A drug where there is some hope that it will be active in HER2 mutated non-small cell lung cancer is taloxotinib, where we have data on actually very few patients, and I hope we will see more of this drug. Targeting combinations, pertuzumab, trastuzumab, not so active, I would say, with an objective response rate 21% in mutant patients. And there are ongoing studies combining trastuzumab with a tyrosine kinase inhibitor and trastuzumab deruxtecan with pembrolizumab. So we will see the results of these combinations in the near future, or in the next couple of years. So, Yarushka, I'll start off with you. What do you think is the most promising agent at this stage?
Yeah, well, I'm biased and obviously related to some of the data that you've presented, but I think TDXD is probably the agent I'm most excited about in this setting. The reason for that is because there are very promising response rates. It has proof of concept, and it has shown its activity across multiple different tumor types that have HER2 as the oncogenic driver, not just lung cancer, but also breast cancer and some GI malignancies. So that's why I'm most excited about it. However, there is a caveat to that. We know that this sort of class of agents appears to have a pathognomonic toxicity in interstitial lung disease. This is usually a problematic toxicity, particularly in patients with lung cancer, in order to truly diagnose it and differentiate it from other lung comorbidities.
Yes.
I think that's an important agent.
Yeah. So there's much talk about the dosing of TDXD in non-small cell lung cancers compared to other malignancies. Could you comment on that?
Yeah, so my understanding is that the dose that is being taken forward is the 6.4 milligrams per kilogram every 3 weeks. I know this dosing schedule is a little bit different and attenuated, compared to others, to other tumor types. But so far, it appears that the toxicities are still are manageable at this dose level.
Okay, so the hope is that with lower doses, you would have less ILD in this patient population, correct? Favorable results can also be due to patient selection. Do you think there's any difference in the population enrolled in these studies with monoclonal antibodies or ADCs and tyrosine kinase inhibitors?
Yeah, I don't appreciate any major differences between the populations. Again, we see an enrichment of never smokers or non-smokers, females, around 40 to 50% of patients with brain metastases, similar to the population we expect. With some of these agents and some of these trials, such as the RAIN 701 trial, the tarlatamab trial, there are very few patients in that study, just 9, 2 of 9 responses. So I don't think we can say that we really understand or the population is necessarily represented by such a small group. But I don't appreciate any major differences between the studies.
So any comments on the brain mets issue?
I don't think there's any obvious data to suggest that one agent is preferable to another with respect to brain mets as yet. What do you think, Egbert?
I agree, because it has not been analyzed separately. My hope is that we get more and more information on patients with brain metastases as these are allowed to enter on the trial. I think that's a major difference with, let's say, 5 years ago, where these patients were systematically excluded from participation in trials. And I think that's of critical importance. Okay, so we will, I think, of course, we have not solved the problem of HER2 mutated non-small cell lung cancer. And I think combinations are going to be critical for further improvements. Katrina, what do you think what's the way to go ahead there?
Yeah, so I think we're seeing some interesting preclinical studies that are being conducted looking at combinations. And some of these studies are of tyrosine kinase inhibitors, so the small molecule inhibitors, in combination with these antibody drug conjugate molecules. So a kinase inhibitor plus an ADC in combination in the animal model seem to have efficacy and lead to tumor regressions that are more durable than maybe an individual agent alone. So I think potentially exploring and looking at these combinations clinically is going to be an interesting avenue going further. I think that also one of the things to keep in mind is, since there are different mutations in HER2, there might be different approaches for different mutations. And that's where really in-depth studies of the biology, the biochemistry of the mutations, and some of these are definitely being done by various colleagues, and understanding then the therapeutic sensitivity of these alterations, alone or with different combinations, is going to be really helpful to optimize the type of ways in which we can treat patients with these who have tumors with these different HER2 mutations. And that's especially in a setting where you have a variety of agents and options that can be compared and studied. That can be really valuable, is understanding the specific mutations.
I know maybe it's not a good question for you, Katie, but given the normal physiological role of HER2, do you think it's feasible to block the function of HER2 entirely by combining a monoclonal antibody and a tyrosine kinase inhibitor?
I think that, some of the, when a tumor cell is dependent on driver oncogene for its survival, ideally one would really like to be able to get rid of it and block its activity most effectively as possible. So that's definitely a strategy to get rid of the tumor. Of course, this does the more effectively you do that, the more toxicities one could imagine happening. And so that's just, that remains the challenge, I think, with many of these approaches.
Okay. Yarushka, what do you think? All together or one after the other?
Well, I think that will be the next wave of clinical trials. That's for sure. The complexity in lung cancer is increasing. I'd like to echo Katie's point on knowing the specific type of alteration. I've had a series of patients with YVMA alterations who appear to have a different biology and don't necessarily respond to the same agents. So I think our knowledge of genomic alterations is going to have to become deeper. And as oncologists, we will have to be familiar, not just with the fact that a HER2 mutation exists, but also what that mutation is.
Okay, I think those are fine last words, Yarushka. Thank you very much for your participation in this discussion. I enjoyed it very much. And I would like to thank you for watching this discussion about HER2 dysregulation and novel targeted therapies in non-small cell lung cancer. We hope it has been useful for you. Thank you very much.